Hello guys and welcome back to my channel Clinical Cases Simplified. So here we are with the next case, so let's dive right into it. While working in a laboratory, a medical student accidentally opens a canister of highly corrosive gas and inhales a large quantity of the gas. He immediately goes to the emergency department for the evaluation and treatment. Physical examination shows labored breathing and tachypnea as well as scattered crackles and tachycardia. So what we can infer from the case is the medical student suffered an acute injury to the lung. So what conditions could be included in the differential diagnosis? So from the history given, we can infer that the patient may suffer from non-cardiogenic pulmonary edema, acute pneumonitis, and acute respiratory distress syndrome. And the onset of symptoms may take up to several days depending on the severity of the insult. If protein-rich exudate is found in the alveoli, what diagnosis is likely and what's the mechanism of disease? So we are basically seeing the pathophysiology of ARDS or acute respiratory distress syndrome. Acute respiratory distress syndrome, the name itself says it. Acute means rapid, respiratory distress means breathing difficulties, and syndrome is a group of symptoms that arise from any cause. So let's review this in detail. Protein-rich exudate in alveoli suggests diffuse alveolar damage, which may lead to acute respiratory distress syndrome. The alveolar damage results from toxic neutrophilic substances, oxygen-derived free radical, activation of coagulation cascade, all of which are stimulated by some inciting agent, here in this case the corrosive gas. As a result, the alveolar capillaries become more permeable, allowing the leakage of protein-rich exudate into the alveolar space and subsequent formation of intraalveolar hyaline membranes. That is seen histologically. The hyaline membranes interfere with oxygenation, producing hypoxemia. So here we can see the pathophysiology in a diagrammatic form. So the cytokines are released into the bloodstream or by the alveolar macrophages that basically are TNF alpha, tumor necrosis factor alpha, and interleukin 1. These cause these endothelial cells in the alveolar capillaries to express certain adhesion molecules. These adhesion molecules, the cells of immune system, they come and stick to these adhesion molecules and they eventually enter the alveolus. There they do a lot of things because of activation, like releasing proteases, leukotrienes, platelet activating factors, cytokines, etc. So they cause basically inflammation. So what's the result of this inflammation? The result of inflammation is more coagulability of blood, means the more blood clots. The endothelium, this space becomes widened, the endothelium becomes leaky, that leads to edema, pulmonary edema. Alright, the pneumocytes, the cells of the lung, alveolus pneumocytes, they get injured. So if type 1 pneumocytes are injured, there will be less gas exchange because their main function is gaseous exchange. While if type 2 pneumocytes are injured, there will be the inactivation of surfactant, less surfactant will be released, and so there can be the collapse of alveoli. And finally, as a result of after inflammation infects, there can be the formation of hyaline membranes around the alveolus, which can make the gas exchange even more difficult. Alright, so there as you can see, the perfusion within the capillaries will be okay, but the air exchange through the alveoli won't be the same. It is decreased, so there will be VQ or ventilation perfusion mismatch. This results in hypoxemia or cyanosis, which we can often see in the patient of acute respiratory distress syndrome. The hyaline membrane formation is further enhanced by these macrophages. These macrophages are still there to clear the debris, the inflammatory debris created by these immune cells of immune system. So these also activate these fibroblasts, which leads to further deposition of hyaline membrane and scar tissues. If the patient recovers, there will be a chronic lung injury, permanent lung injury. Here you can see histologically there are these eosinophilic thick walls of the alveoli. Usually the alveolar walls are not so thick. They are designed in such a way that they can perform gas exchange very easily, but in this case they are thickened, so there will be lesser gas exchange. So how do we arrive at the diagnosis of acute respiratory distress syndrome? So there are 4 criteria. First of them is, the name says, acute. That means the symptoms should be occurring within the onset of symptoms would be less than 1 week, and you can see white out appearance on the X-ray or the CT scan. The PF ratio, or the ratio between the partial pressure of oxygen in the arterial blood to the percentage of oxygen in inspired air, also known as FiO2, or fraction of oxygen in inspired air, is less than 300 millimeters of mercury. And the final, respiratory distress should not be caused by heart failure. How do we rule out heart failure? Heart failure can be assessed with the help of cardiac ultrasound. In heart failure, it is caused by the increment in the pulmonary blood pressure, but here in this case the pulmonary blood pressure will be normal. So on the X-ray you can see white out appearance all here and here, because of the bilateral diffuse infiltrates in the lung. So if this condition does not resolve, what complications can arise? If untreated, the persistent inflammation in hyaline membranes promote organization of damaged tissue, resulting in irreversible fibrosis. What causes this condition and what's the treatment? There are many causes of ARDS like sepsis, acute pancreatitis, gastric aspiration, pneumonia, trauma, transfusion related acute lung injury, and shock. The treatment of ARDS must address the unique underlying cause. For example, if it is caused by sepsis, we can treat sepsis first of all. If caused by gastric aspiration, we can treat that first of all, and so on. However, oxygenation using some form of supplemental oxygen or mechanical ventilation is typically the cornerstone of acute management. So we had to provide the mechanical ventilation, making the positive and expiratory pressure that does not let the alveoli to collapse, and there will be low tidal volume in order to prevent overinflammation of alveoli, as the alveolar walls are already weakened because of the inflammatory cytokines released over there. So this was our case on acute respiratory distress syndrome. Thank you so much for watching this video. See you next time.